Welcome everyone to the second in our Beyond COVID series at CID. I'm thrilled to have our panelists today. I'm thrilled to have you join us for this important conversation. Just to remind you, my name is Asim Khwaja. I'm the Director for the Center for International Development. And we have started hosting these webinar series called Beyond COVID, where the idea is that we're trying to bring together experts in this field, both within Harvard, but also experts outside to talk about various issues. The first series we had was on education. Today's series is really talking about health equity in the context of vaccines. What we have today is an amazing set of experts who've thought about this question, who have practiced in this area, and I'm sure we'll have some amazing things to say. I've posed sort of 3 questions to them, and as we turn to each one of them, those questions are broadly going to be kind of what the challenge they face in vaccine distribution, what are some of the positive signs or hopes they've seen, and importantly, what are their ways forward, both for this current pandemic, but also more broadly as we think about equity of healthcare services. How do we think about those issues which this pandemic has really brought to the forefront? Let me very briefly introduce the panelists. We will put the detailed bios of each panelist in the chat so you can see how impressive a set they are. I'll briefly introduce them in the order in which I'm going to request them to make their opening remarks. First, we have Rebecca Weintraub. Rebecca is a member of our own faculty. She is at Harvard, and she directs the Global Health Delivery Project at Harvard and Better Evidence at the Aradne Labs. Once Rebecca shares her thoughts with us, we have the pleasure of having Thabani Mafosa join us, who's the Managing Director of Gavi. I'm sure you guys are familiar with Gavi. They've just done some spectacular and amazing work. So I'm just thrilled that Thabani is here to share the work they're doing with us, and hopefully some areas of further work that he has in mind that he'd like to share with us. And then very close to home, my dear colleague who every time I talk to, I learn tremendously from, Matt Andrews, who is the Edward Mason Senior Lecturer at International Development at Harvard, but also heads the Building State Capabilities Program, which has just been doing some fabulous stuff in terms of thinking through managing development, and in particular in the pandemic, managing crises. And so I'm just thrilled to have all 3 of you join. With that, Rebecca, I'm just going to turn over straight to you. The floor is yours.
So many thanks for having me, and so thrilled to be in conversation with my esteemed colleagues on this panel. I thought I would just start us off to think through, and in a sense, then go through a series of proposals why we continue to have a supply and demand mismatch. And this is not related to the vaccines being new, but actually has to do with the underlying data and information infrastructure we have to invest, procure, and deliver vaccines across the globe. So in a sense, these issues are endemic to any vaccine rollout, not only COVID-19, but obviously the exacerbation, the timeliness, the speed in which they were not only discovered, but manufactured has even unfortunately exacerbated the decentralization of the infrastructure that we're within today. And I think of the proposals that have been discussed at the tables with multilaterals, for example, bilaterals, and within countries really fit in 3 buckets. First, in discovery and production, second, in procurement, and third, in delivery. And so I'll share with you a few of what I think these proposals have come to bear, and then I'm hoping we'll spend most of the time the second part there discussing many of these. So in the discovery and production phase, as many of you are aware, there's been this notion of adopting a TRIPS waiver to remove the critical intellectual property barriers in order to scale up vaccine production across the globe. Number 2 is to incentivize our pharmaceutical companies to voluntarily license the COVID-19 vaccine patents, either to manufacture in a low and middle income country directly, or through a multilateral mechanism, such as the mRNA Vaccine Technology Transfer Hub. The third is to impose a federal waiver on intellectual property related to COVID-19 vaccines within the US federal jurisdiction. Number 4, we find the idea of financing a technology buyout, where the US federal government offers these companies a lump sum payment in exchange for the COVID-19 vaccine IP. The 5th is investing, as we know, in vaccine manufacturing infrastructure. And we've seen some really creative multilateral partnerships, for example, between the Republic of Senegal and the EU. The 6th is actually supporting efforts to evaluate and implement dose stretching strategies. And remember the experience that we've seen from the UK as well as India, and where and when those should be adopted. Quite telling on a day as of today, for example, when 3rd doses boosters will be made available to all adults in the United States of America. And the last is really, how do we harmonize regulatory processes? So during a pandemic, the local trial requirements for vaccines actually are quite stringent, and which of these should be waived in the midst of an emergency? Now, to move to the second bucket, procurement. So what are the proposals on the table to gain some efficiency in procurement? First, many have suggested the countries should fulfill their dose sharing pledges immediately, and ensure that COVAX and the African Union African Vaccine Acquisition Trust actually has the doses that have been pledged. The second, that Gavi and CEPI should be able to leverage their mechanism of advanced purchase agreements and provide concession loans to encourage vaccine manufacturers to expand their capacity immediately. The third is to develop other private financing solutions, for example, a bond, which would proceed and could be channeled to vaccine procurement. And then there's also the need for bilateral partnerships, particularly with certain high-risk countries, to complement the ongoing multilateral efforts on the table. And then the third bucket, which is where I spend most of my time, is really thinking through the nuts and bolts of how do you deliver a vaccine in the midst of a pandemic? How do you not disrupt routine immunization programs? What are the services you need to upgrade the infrastructure? So the flow of information, the flow of the product, and the flow of the financing. A set of proposals have been proposed. For example, we also will need a global database of the critical raw materials to ensure the supply is sufficient for the manufacturing capacity that's been developed. We'll need to ensure free cross-border flow of these raw materials. And then there's a set of proposals on the table that really mimic and remind us of the existing infrastructure that's been built by PEPFAR and the Global Fund and others, and how to build upon the infrastructure that we've invested in, for example, with respect to the President's Emergency Plan for AIDS Relief. There's also a series of proposals and wonderful suggestions about how to integrate COVID-19 vaccine into primary care operations, and to not exclude this or make it an exception versus add this and enhance routine immunization. In addition, the idea of deploying biometric digital IDs so we can identify patients to address the lack of formal identification, keep track who's been vaccinated, ensure they can return for additional doses, and decrease wastage. We can leverage the data to predict immunization behavior. So we can, in a sense, not only use the data from routine immunization programs, but satellite imagery, digital conversations to predict who will come to what site. And there's, in a sense, a whole host of suggestions regarding how do we build upon, for example, cold chain technology, the drones, for example, that we leveraged, some during the Ebola crisis and some that are in early demonstration efforts in several countries, for example, in Ghana. And I'll just leave kind of my opening remarks here that what we see and the imbalances that we continue to see across these countries are truly related to the infrastructure of global systems, the flow of the information, the difficulty for countries to predict the demand that they will need and where to locate the product. And how do we think about, not only in the midst of the COVID vaccine, obviously, but how these recommendations actually, in a sense, help us upgrade the conditions that led to this crisis in the first place. I will turn the baton back to you.
Thank you so much, Rebecca. Tabani, why don't we jump straight in? Over to you.
Thank you so much. And thank you, Rebecca, for your expansive views on these issues. And when I think of the subject at hand, I think you know, what has been the biggest challenge or what has been one of the biggest things that we have underestimated. I think geopolitics is something that we truly underestimated when it came to this pandemic. We have seen this at play from the beginning until now. It plays in overt and sometimes in subtle ways. Who before now would have been familiar with vaccine diplomacy? Who would have thought that vaccines would fall into that fray and that space? I have often argued that if ever there has been a vaccine that has been a political vaccine, this is one of them. It is extremely political, both in terms of supply, in terms of distribution, but even in terms of when you think about the ways in which the countries think about responding to it. When I think, for instance, about Africa, I see that there's two tracks in relation to this vaccine. There is a political track where leaders in countries have taken a posture that is leaning in significantly into immunization than we have ever seen them before. But yet you see a fault line between the political leadership and the programmatic and technical leadership that is involved in this work. So to sum it, I do think this has been the political vaccine of our lifetimes. The biggest part of the politics has really hinged around inadequate supply. And this inadequate supply and scarcity obviously triggering a number of behaviors that have been extremely challenging, both to the multilateral system, but to the way in which we think about pandemics and diseases as well. Then at country level, one of the things and one of the terms that we at Gavi have been using quite often is heterogeneity. You cannot treat Bangladesh the same way that you treat Pakistan or Central African Republic. Of course, it is a given that these countries are different, but never have their differences been as accentuated as they are now, both in terms of demand, infrastructure, and really their true ability to be able to deliver these vaccines. We have also seen vaccine competency being an issue in a number of places. More specifically, we have seen it in West Africa, and we have seen the power of social media in terms of driving this, but also the opportunity that sits with social media in containing vaccine hesitancy issues as well. Then we speak about what have been the signs of hope that we have seen in this response effort. I think the first sign of hope is really characterized in what Rebecca called the discovery and development space. Never before have we seen the world come together so well to actually accelerate vaccine production. I mean, the surge at WHO just last month announced the malaria vaccine for children. And guess what? This is something that some people have been working on for 15 to 20 years. And so our ability to really shorten the cycles and for the world to come together is a sign of hope that needs to be celebrated here. Then when I think about our very own COVAX facility that we have set up, it's set up the first humanitarian buffer, which is a pool of approved COVID-19 vaccines to be available to humanitarian settings. Something that offers a glimmer of hope in how we think about these marginalized communities amongst us. Then when I think about the Gavi Alliance as a whole, never has our operating model been so relevant in terms of the alliance platform and what it can deliver through UNICEF, WHO, and bringing in CEPI into the fold, but also a whole lot of other partners like the civil society and other players, the private sector, that had to come together. As of this week, we have been able to deliver 500 million vaccines to a number of countries, most of which are LMICs, which have only COVAX as their only hope to deliver vaccines. What are some of the key lessons that we really come out with here? The one that we have been speaking and singing as a mantra is that no one is safe until everyone is safe, and that is true. We have seen how variants have really taught us that if you are ahead, but you are not actually taking others along with you, a variant may come from one space and really reverse the progress that has been made. Then the second one is that the investments that we have made in peacetime have really been a very important infrastructure that we have been able to leverage. Let me speak about technology in particular. India has vaccinated or put out doses over 1 billion, and it has used infrastructure for capturing that that was developed through the routine immunization side. And so there are things that can be leveraged from our work that was already ongoing. But I also see an opportunity as well coming from what Rebecca said, which is some of the technology and things that we have been trying in a pilot manner, like the drones, are going to actually find an opportunity in this crisis to actually be used more broadly. So there is an amazing opportunity in this crisis. As much as there's challenges, we have a lot that can be done. But our work is not over. One thing that I've learned every day is that we have to work up with an improvising mindset because the pathways that we know don't always work on an everyday basis. Rebecca spoke eloquently about the need to increase the dose donations and what have you. But I would also be the first one to tell you that dose donations don't come without challenges as well. Sometimes they come with challenges of short shelf life that we have to try to deal with. We are beginning to see product preference in some places, and these are issues that we have to solve for on an everyday basis. But not to forget, because I'm Gavi, I would have to speak about routine immunization. Routine immunization is fighting for, it's on the ICU bed, fighting every day for survival. And that's not a good place to be because that means there's a lot of children who actually may be exposed because of our response in the pandemic. And it is important as I end to recognize that as we respond to this pandemic, the principle of doing no harm has never been as important as it is now. Thank you.
Thanks, Tabani. That was really powerful. There are lots of ideas there, what I want to explore in the discussion. But before I do that, let me turn over to Matt. Matt, all yours.
So yeah, thank you to both Rebecca and Tabani. So great to be a part of this. I'm going to offer a little bit of a different perspective. I think that certainly there's a global dimension to this. Certainly there's a dimension of that we should all be thrilled about, you know, the pace at which we managed to, as a global community, kind of work out how to get to these vaccines in multiple different countries, multiple different parts of the world. And I think very interestingly how the different relationships of different countries have led to the distribution of different vaccines, but vaccines that we all have fairly good confidence about. So I think that in a sense that we saw a world that is kind of organized according to different powered structures, but those power structures have allowed people to have different vaccines, but still have vaccines. I think that you've both described some of the legal issues, some of the trade issues, some of the issues that emerge in terms of how global bodies need to be working together. And I think in most cases, we can report that there's progress on all of these things. And in most cases, we can say that, you know, Pfizer is negotiating with people to be able to have these vaccines produced in other places at lower costs. And you know, these things, some of these agreements took a long time with respect to things like AIDS drugs, right? They took much longer than this. So we've done well. My area of work and my biggest concern is, okay, so if we manage to get these procured, if we manage to get these procured at prices that are acceptable or accessible, if we manage to get them onto ships, what happens? How do we get them from the ports to the patients? How do we do that? My biggest concern here is that we've been talking about the global system, and I think that the global system has responded well, not always cleanly or neatly or easily, but I think that kind of it's responded well. What about the country systems in the countries that are most affected? And I think this gets to where Tabani ended up, that, you know, what we've actually seen is that a lot of countries where you've had great progress in vaccination in the last 15 to 20 years, you get to see that the systems are not as resilient as we'd like them to be. And that actually the kind of vaccination progress we've had with other vaccinations has kind of fallen off during this period of time. And I think that that needs to be something that is a lesson to us. People have spoken for a long time about, you know, delivering health services versus building health systems in developing countries. And I think people have said, we'll get to that, we'll get to that, we'll get to that. Well, we need to get to that. It's really, really important because, you know, in many of these countries, the systems aren't being as resilient with even the vaccines that we were doing well with before. And now we're saying, well, let's bring another set of vaccines in. We'll get all the patents, we'll get all of the international agreements done. They're going to sit at the ports. My engagement with vaccines, my engagement with medication has been with medicines has been that in most countries that I work in, the countries manage to get them, but they literally sit in containers at ports. And, you know, this is a big issue, and it's a big issue now, and it was a big issue 15 years ago. Where I've seen it being solved, it's been solved by the intervention of organizations like Gavi, by other entities that actually come in and say, okay, let us help with those supply chain issues. Let us help with those logistics. Let us bring kind of private sector people who can help from across the world. Well, those people aren't traveling that much anymore, and those solutions aren't working that well anymore. So I think that we have a really big challenge with this. I think that this is going to be the next step, and I think that we really need to focus on this very much. Now, what are the things that we need to focus on? I think global logistics are going to be a problem. We have global logistics problems with regards to everything right now, and getting some of these things just on those ships to the ports, I think that's going to be a lot harder than what we think. But then when we do get to the ports, I think that we need to really be working on logistics in these countries, where this issue of equity is the biggest concern. because we don't want it just to get to the port. We don't want it just to get to the capital city. We want it to get to the countryside. And this is not just something that's a problem with medicines and vaccines. It's a problem with everything. So we have a gigantic opportunity here to really say, for now, let's not talk about systems, but let's really get to systems quickly. This will mean thinking about how do we rapidly improve the quality of roads? How do we rapidly improve the quality of basic infrastructure? How do we also think about communications? In many of these countries, logistics is not just getting the goods to people, it's building trust in the communities so that the people actually want to take the vaccine. We've seen in developed countries that how much of a problem this is. It's a really big problem in other countries as well. We know with treatments for polio, with treatments for AIDS, with a lot of other medical interventions that oftentimes the drugs have been available, that we've been able to get them to people, but people don't trust the people who are giving to them. I think communications is huge. And if there's anything we have learned from some of the countries that we've been talking about now, is, we need to work on that. So I think there's logistics issues, there's communications issues. I think there's also issues to do basically with public finance. How do we help countries finance these things, not just in a one-off, but how do we help them think about financing this in the long run? And I would say here again, it's also thinking about financing vaccines in general, medicines in general, because oftentimes I work in countries and the financing situations, the financing solutions, the logistical solutions, they're coming from the outside. They're still coming too much from the outside, and we need to use this as an opportunity to build resilient systems, financial systems, logistical systems, communication systems, political systems in the countries that have been left behind, where we're trying to play catch up. Now, I think that there's a lot that we can build on. There are countries where you see logistical solutions that are working quite well. I've been reading about cold chain advances in Rwanda that are proving tremendously valuable at this point in time. Some of those advances were not advances that were made within the health sector. They were advances that were made in the name of kind of economic growth, developing cold chain solutions at airports so that you could trade in flowers, for instance, in a place like Burundi. Well, now those solutions are accessible for us to be able to use vaccines. The idea of being able to mobilize mass vaccination structures in places like Angola. Again, this is piggybacking on some of the work and some of the advances that happened before. So I think that we have answers, and I think that we need to look for those answers in the countries themselves. And we need to say, where possible, whatever we do to distribute these vaccines, can we make sure that we are investing not only in getting vaccines once to these places, but ensuring that they have country systems to keep doing it with the other vaccines that we want them to keep distributing after this fact. And I think this is a great opportunity for that. I think that we already have many opportunities to leverage, but I think there's a lot of work, and I think more than a lot of work, I think that there is a mindset shift that is required to say, it can't just be about delivery, it must be about systems. We've been stuck in that discussion for a long time, and it's about time that we shift ourselves to say, we need those systems. They weren't here for the last couple of years. We needed them then. As Thabani said, we've got a major problem with vaccination programs that were working really well before that aren't working now because the systems aren't as resilient as they should be. This is our opportunity to get it right and to do it properly.
Matt, thanks. This is a great spectrum. So let me say two things. One, before we jump into the discussion, feel free for those in the audience to post questions as a Q&A. I already see a question in there. So please go ahead as we're having our discussion. That way, the minute we're done with our discussion, we can quickly turn over. So just type your questions in the Q&A feature. Second, I'm going to take advantage of the fact that I'm sitting at the Kennedy School, and I want to start this discussion touching on a couple of themes that you guys have both raised, which I would broadly describe as sort of governance of this. And I think that I love the contrast between kind of all of what you said in terms of sort of and I know, Rebecca, you've used this word before about sort of vaccine nationalism, and Thabani, you've used the word vaccine diplomacy. And Matt, I'm going to rephrase what you said with sort of the local last mile delivery problem as well. And so in each of these areas, there is a governance aspect of these areas, whether it's politics or it's logistics. My question back to you all is, as you think about these governance issues, and we can start maybe with the national and the kind of international aspect of that, all the way to the local, what are the specific things you've seen, best cases, things which have worked well? And let's start first with the state itself. We can bring in other actors, but I want to focus on the state and the states in general, and say, what are positive things you're seeing happening that we can push on? And frankly, what are pitfalls you're seeing over here? There's a dark side to all of this. As much as we celebrate the successes, there are some sort of, to Rebecca, to your point, nationalistic tendencies. Are we truly, Tabani, taking the no one is safe till we all are, truly internalizing that? Or are we building higher walls to keep us safe as opposed to helping each other? So let me pose that question back to you. And maybe, Tabani, we can start this time with you in your Gavi hat and say, you must be in the firestorm in the middle of all of this, and tell us how that's playing out. So starting with you.
Sure. I'm trying to think what is the best place to start, but maybe let me start where it hurts. Where it hurts for me is the fact that where an opportunity to actually come together and pull together has been turned into a competitive space and a competitive, instead of bringing all forces, and here I'm talking really at the global level, and I'll speak. I think this is a function of scarcity. What scarcity does is that it says every man for himself, and a higher power for for all of us, and I think that's what we saw. It was I'll watch out for myself, and so even as we tried in the COVAX space to broach this idealistic idea of equity, it was challenged, and I'll give you an example. The Africa Vaccine Task Force, which is a very important player for Africa, at some stage may have seen us as not necessarily supporting their goals, because they were looking at finding vaccines, and we're looking at finding vaccines. And it has taken us much longer to come to that point of synergy. I'm glad we are in a space where our collaboration is stronger. But if we had collaborated much earlier, we would be much further than where we are. At a country level, I think Matt really hits it right. The equity issue becomes quite an important one that needs to be thought about in terms of how it is looked at and thought of as we think about, as we really think about vaccinating the countries. These urban areas are easier to actually absorb, and we can really go through the Robert Chambers idea of reaching to those who are next to the highway. But how about those who are much deeper, and how does the system think about those people? And I think Matt is actually extremely right at pointing out that this may be something that is in the blind spot, because at this particular point, Gavi included, our biggest concern is that no vaccines go to waste. And that means no vaccines go to waste may mean all vaccines go to urban centers that are able to absorb them, and it may actually then forget the person who is in rural areas who needs to be brought along as well. So I really appreciated that that element of equity, and I think we should keep on checking our blind spot, because it is one that could easily be on our blind spot.
Rebecca, vaccine nationalism, problem just for the rich, or everyone's problem, and how do we break it?
Thank you for asking the question, and I'm excited for the ongoing discussion about this. Just honestly, when we pointed this out early on in the pandemic as a known pattern, this isn't a new notion that we see hoarding happen. This has very clearly happened during H1N1. And just to be honest, even trying to get the word out that we were concerned about vaccine nationalism was rejected by every major American newspaper early on in the pandemic. And many folks on this call have been through other pandemics, and they saw this was going to be happening, including Seth Berkley and others. The concern was there. It is just what you're mentioning. What are the governance structures we need to mitigate this notion of I will over procure for my nation state, and only then will I begin to donate, which we saw in H1N1 as a pattern as well. So we didn't solve for that, even though that did occur during H1N1, and the repetition of that and the politicization during the previous administration's Operation Warp Speed made it much more difficult for any other nation to begin the procurement process and capture the attention, for example, of Pfizer or Moderna, to have a conversation with the CEO of the company. And this is problematic when a leader of a nation can call a CEO of a pharmaceutical company and their procurement and their fulfillment of the order happens faster than others. That's not optimizing regarding viral transmission. That's not optimizing to unfortunately caring for the vulnerable. And it's not helping us break transmission and the speed of transmission. So Mark Lipschitz and others have spoken about this and written eloquently about how best do we actually optimize and distribute even a scarce supply. And that unfortunately wasn't followed truly by only any nation state truly followed that. There was elements of that. It's the first time that we took into account vulnerability and how we thought about allocation in the United States, for example. But what you saw, even, not even, but, and as an example within the US, we also had that heterogeneity that we've just spoken about within each state within the United States. And that also led to many waiting for their second dose, not being able to access it in those early days, even as eligibility altered over time. So I also just want to remind us that we'll actually have 14 billion vaccine doses by year end. And that is kind of an amazing manufacturing, another point, Matt, to your point, not only discovery, but the ability to have the supply, it's in the distribution. And then obviously what needs to happen from port to patient and that chain of services that needs to be obviously provided and verified and secured to care for the most vulnerable.
If I may, this is a great segment to Matt. Something you've said, this kind of last mile port to patient, as you put it. Tabani mentioned something which is a cautionary tale to that, which is in the interest of getting vaccines used, do we end up, because of our local logistics, the world isn't a flat plain. The world has hills and troughs and valleys. Walk us through local delivery. And I know you've thought a lot about local government as well, mayors, like who in the government is going to do this? And what is their blind spots? Is one of the blind spots going to the highway and not the village on top of the hill or in the valley? How does that work out?
So, I have actually been working with a number of countries in the last while. Most of the people that I've been working with have been at the national level, and I'm sure that that's probably the case for most of us. And so the first thing that I'd say is kind of even now working out what's going on at those local levels is quite tricky, especially when you start to move beyond capital cities. I think what, the comment about national leaders calling, CEOs of big pharmaceutical companies and negotiating access to vaccines, you can't do that if you're the mayor of a small town. So you're not even on the phone with people who might be able to think, like us, who thinking about capabilities, etc. I would say though that just before the pandemic hit, I started working with some very, very kind of rural clinics in an African country for the first time. And so I was engaging with them through this period. And, if the first thing I would say is this, I think that a lot of, and these are now some of the anecdotal kind of concerns that I have of working with folks like that, working with others. I think that you have vaccine nationalism, meaning kind of, people are saying, I want to keep it and I'm gonna overorder, I'm not gonna share it. I think you have vaccine classism going on. And I hear from a lot of people saying, who in my town needs to get the vaccines? Who in my country needs to get the vaccines? One of the biggest concerns that I have when I look at the building of state capability and at the development processes we've seen over the last 20, 30 years is that development has worked really, really, really well for elites in countries. And what I hear oftentimes is people saying, we need to make sure that the people who need to travel internationally, the people who are already plugged into the global economy, that they get the vaccines quickly because, they're the ones that keep our GDP going. And I'm really, really concerned that, we might exacerbate some of those some of the inequalities that we already see through this process, which I think Tabani related to just now. One of the areas that I see, it's not just kind of, let's make sure we get it to the highways. It's like, let's make sure we get it to our people around the highways. In a lot of countries in Africa, even in the Middle East, even in South Asia, I'm really concerned about the fate of migrant workers, for instance. That where do they fit on in this process? How do they advocate for themselves? How do they get the vaccines? But when you talk about kind of how does this actually work, you can think about how it works in capital cities close to ports, whether it be a seaport or an airport, much easier than you can think about how does it get into the hinterland where you have those kind of hills and those valleys. And even the examples that I was talking about, you have cold storage in Rwanda, close to the Rwandan airport. Why? Because, it's designed to be there so that you can service industries and you can help them trade. It's the same in Burundi. It's not the same if you move kind of 100 miles away from the airport. You don't have those facilities. It's the same in Angola. The examples that I see in Angola where you've got mass vaccination sites that are working really well, the logistics around that work very, very well. Those are going to be in Luanda, they're going to be in big cities because you have kind of mass distribution programs for things in those places that already work. Getting them out into the rural areas, this isn't even talking about 500 miles from the capital city. In Mozambique, this is talking about 50, 60 miles from the capital city. Is really hard because you have a major equity issue just with capability. State capability has been built around the highways. It's been built around the capitals, and a lot of other places have been left behind. You go to those areas and you find that you don't have doctors, you don't have skilled nurses, you don't have much capabilities in terms of equipment. You don't have access. The roads are bad. And that's the norm, not the exception in many of these countries. So I think that we really, really are going to struggle to work out how do we get it to these places when we don't have what we've had before, which would be international organizations mobilizing international people coming in and doing big vaccination kind of outreach programs. Now you're going to be saying, okay, it has to go through those clinics and it has to go through the nurses in the clinics. Now, we don't have the capabilities, and I think it's worse than it was before. As I said, I started off saying I was working with some groups throughout this process, and I'd love to say that I was on Zoom with them. I wasn't on Zoom with them because they don't have Zoom, because most of them don't have access to this. Most of them we're talking on WhatsApp because it's kind of easier to talk through. And I would say that many of the health workers in those places are stretched beyond belief. And they stretched beyond belief not because of COVID yet. right? They stretched beyond belief because the support mechanisms they had before COVID haven't been available like they were before. I think that we need to be really concerned, as we are in all countries, with burnout in the health sector. And if you have burnout in a sector where you didn't have enough people beforehand, you have a real big problem, because they're going to be the ones who have to distribute these things. The other thing that I think is going to fall onto health workers and onto mayors and onto local politicians and local bureaucrats is the communication challenge. How do we deal with misinformation? How do we, these are big issues, and it's not necessarily something that these folks had to deal with before. When Liberia was dealing with Ebola and there was misinformation about Ebola and there was a communication challenge, a lot of the people who helped on that communication challenge were people who flew in on airplanes. And there were a lot of Liberians in the effort, but those Liberians were working together with those folks, and those people are not available to people who are in local areas. Especially when those areas are rural areas. And if the misinformation is happening at that level, it's going to be very, very hard. So I think we need different kinds of support to different people. And really, we need to be thinking about how we get not just to the street level, because in this case, we're not talking about the street level. We're talking to people who don't talk about streets, they talk about mountain pathways. And really, we need to do that if we are going to be clear that this is about equity. Because if we don't reach those people will fall further behind in the global growth process than they already are. And I think it really is getting down to that granular level that we need to think about.
Great, thanks, Pat. I'm cognizant we're going to fast approach the end of time. Let me take another 7-8 minutes, and let's I want to do another rapid round, and then I'm going to open up because there's some fabulous questions from the audience as well. Look, we've talked a lot about the state. I want us to collectively think about the other actors who can help. And you've sort of mentioned these actors. Let's broadly bring 2 other actors in. The private sector. These companies have tremendous power in these discussions. The fact that the CEO entertained that call and not the call from the mayor is a decision the CEO is making, which probably doesn't look great for their CSR, but is a decision they've made. But also communities, local communities. When we talk about vaccine hesitancy, vaccine denial, or even identifying who the neediest person is, do we rely on the state's apparatus of identification, or do we get communities involved? So I'm just going to throw this question back at all 3 of you. You can all unmute, by the way, together. Pick whichever one. Let's bring more actors into the discussion and see how it can again help us.
You see, this question is a very fascinating one, in that when the WHO developed guidelines, the guidelines were clearly following an order of vulnerability. It was the elderly with pre-existing conditions and what have you. And we're supposed to come down to that, to the youngest. The world is not as perfect. It's not so perfect. And so we have seen that not working. But what has really been challenging is when these vaccines have actually gotten to many countries, you find that age group that should be vaccinated having a cohort of those who are hesitant and a cohort of those who are willing to take vaccines. And the practical struggle that we have had to deal with is, do we strictly apply this guidance when we were still actually under emergency use authorizations of these vaccines, which meant that the shelf life was still short. So it's almost multiple tracks that you are playing with to really try to sensitize and socialize those groups that are hesitant, but at the same time, still keeping the principle of saying no doses are actually going to go to waste. And so when we make those pragmatic decisions, what it then means is that we ended up opening vaccines to the next run of the vulnerable group than we should have. and when you think about it, even at a global level, Rebecca spoke about the communication that is going to come out for booster doses, for the third dose, and you wonder if the whole world was thinking together about equity, should we really be thinking about a third dose before someone even gets a first dose? And so I think what I'm simply saying here is that we are untangling a very complex set of issues. It's not linear. It's complex. Even in these spaces where you really want the vaccines to get, so all of us can really fight here and say, well, there are some countries that have been having vaccine nationalism, and you are going to try to knock at the doors of a country in West Africa. Then once you have gotten those vaccines to the ports of West Africa, and maybe even have been lucky to get them to that outpost near a hill, then you get people saying, I'm sorry, I'm not going to actually take this. So you have gone through all these chains, and sometimes you simply never know until you actually get there that you will have that hesitancy. So it's a set of threads that we have to work at the same time in multiple ways. There is a word that I wanted to borrow that Matt said before I close, which was vaccine classism. I wrote an article maybe 4 months back, but this was very much in relation to Europe, when Europe was closing its borders for certain vaccines. Vaccines that have emergency use authorization from the WHO, and vaccines that in some instances are actually donated by some of the European countries, then you hear them saying, but they will not be accepting people coming from Africa and Asia and other places who have been vaccinated by the same vaccine that they are vaccinating their own populations. It just shows you how twisted our world is. Our work is convoluted, it is complex, but we are also dealing with a very twisted world as well.
Matt, Rebecca, other actors to help?
Yeah, I just wanted to add, thank you, Thavan. It's incredibly powerful. I think if we think about who has had early access to vaccine doses and the infrastructure that they had, may it be centralized planning, small countries that can reach out and, for example, in exchange for doses, offer their data, which we see in Israel. Most countries in the world do not function in this way. And there's such a disconnect between clinical service delivery, public health infrastructure, including the United States of America. And I just bring this up because we are not an example to follow. We have 64 jurisdictions, and the complexity of reporting and the unfortunately, I would say, incomplete data sets that are being sent to the CDC and the federal government and then sent back for states to do regional planning. States should be, in a sense, in conversation with FEMA in their region, not only by state borders. We didn't see that happening even with, for example, all the technology and CSR and interest for this first wave, nor do we see it with respect to childhood vaccination for the COVID-19 for 5 to 11-year-olds either. So, I just want to, it's almost the work ahead about collectively seeing public health and the link with democracy building, and that the communities that have been so affected and highest risk of COVID risk is actually about their community risks, their lack of access to a healthcare provider. They've been told not to return to a health system. They're working shift work where it makes it impossible to schedule and very difficult to schedule an appointment. And what we see that, and having deployed a set of public data sets to look at vaccine deserts, these are also news deserts where people have limited access to the information sources or to be able to triangulate information sources. They're primary care deserts. And I think it just speaks to our collective conversation here that what we've seen is a symptom about vaccine inequity, but it's obviously these underlying inequities in infrastructure behind it. And I think it's in those areas where these many communities are susceptible to misinformation. There's a void, there's a leadership vacuum, and then we know that the WhatsApp channels and the Facebook feeds are filled with misinformation. And we can change those algorithms very quickly to upgrade the quality of information that the public is seeing. That part of the solution is fixable. What is, just in back to Tabani's point, like the messenger themselves needs to be that local provider. And that's polling after polling has shown that it is not the government. It may not even be the health commissioner, but it is your local provider coming out and saying, I vaccinated my family. I want to help you stay safe and to help your family stay safe. Please come with me to get the vaccine.
Great. Matt, before I turn to the question, just a quick response from you on this, and then I just want to move straight to the questions.
So a quick response from me is just, I think that, when COVID first hit, and I would speak to government people, the first thing they'd say is, we don't have enough, whatever comes next, to deal with this. We don't have enough money. We don't have enough knowledge. We don't have enough, we can't do this. And the answer is, nobody had enough of anything because it was new. And for a lot of countries where we're now talking about how do we get the vaccines to those folks who need it the most, who haven't had it yet, it's still going to be a new challenge. And the answer is we don't have the resources, we don't have the money, we don't have the logistics, we don't have all of those things. So our only chance here is to mobilize those from wherever they are and to bring them together. This really is a case where the whole must be greater than the sum of the parts. And the only way that you can get that is if you get people talking to each other and working with each other. I agree with Rebecca, the local health provider is going to be vital in here. Faith communities are going to be vital in here. Local politicians are going to be vital in here. Your member of parliament going, or your local councillor coming and knocking on your door and saying, is there anything I can do for you? It's going to be vital here. Local business people are going to be really important in this. Local administrators beyond the mayor, the people who, your postman, whoever that may be, this is a time where we need to work out how we create genuine contracts across society where people are working together. My sense is that whenever you see this kind of situation turning out into a good story, it's when people work out how to work together. Probably as key to this as they ever are is the media. And I think that, whether you're talking social media, whether you're talking kind of more standard media, it's really, really important that narratives and communications are taken seriously. So this really is a case for people to pull together and for people to work together. It's very hard to do because coordinating across all of these agencies and these entities is always difficult. But I think that really is where the solution lies right now. And the places that are doing well are the ones that are managing to leverage as many different capabilities from as many parts of society as possible.
Great, Matt, thanks. Let me do the following. We have about 7 or 8 really interesting questions. Each one of them are worthy of a whole discussion. What I'm going to do is I'm going to direct these to each one of you, and I'm going to request, rather than us, but if I misdirect it, if you really want to jump in, but let me just do my best chance of redirecting singly. My request is let's do like less than a minute quick responses to these. I just want to get coverage going. So there were 2 questions which were submitted to us by program registrants before, and I want to give them sort of first right at asking. And let me direct these questions. So the first question is, and I want to direct this to you, Rebecca, in the hat you wear under kind of better evidence program. So it's directly on that. How can we use data-driven methods to offer policy recommendations about COVID-19 pandemic for the use of policymakers?
That is a great question. I mean, first, I'd say, don't think policymakers should be the communicators in the midst of a pandemic. And that has not worked. It has not worked in previous pandemics. It barely works when you bring a celebrity to bear. And so to remember, where does expertise lie? And even many of the folks that we lean on in the United States of America in the federal government would prefer not to be the communicators. They would actually prefer to be that local provider who's well esteemed, a local clergy, for example, as well. And we need to equip those folks and train those folks and ensure local public health departments have the utmost. And I think that's what we've seen in many with that vacuum. Unfortunately, people are then looking at their WhatsApp channel, looking at their Facebook feed, versus being able to in proximity. I just also say people have also been told not to go see their provider in the midst of the pandemic. The isolation during the pandemic and the inability to go see a provider has exacerbated the information flow for so many populations. So I just want to share that level of understanding why the vacuum continues.
So let me read, this is a great segment. Maha Rahman's asked from Lums Lahore, this is now to you, Matt. What are the most effective models for information dissemination, countering misinformation in urban centers where societies are less cohesive and mobility is high?
Wow, really, really great question. I think, one of the things I would say is I think the communication is very context specific. So I would say, you can't really say what is the best model. What you need to be asking is, how do people get information that they trust the most in the place where we are? And I think that Rebecca said, the people who should be carrying the message, maybe it's your clergy, maybe it's people from your medical community. I don't know who it is, but you need to be asking in specific places, who do people trust? And who do they trust at I would argue, at as locally as possible, right? On a day-to-day basis. So it's going to be different in different places, and you need to develop your communication mechanism to go through those people. So what I would say is, when you're thinking about the message, you need to think, what is the message? What is the evidence we're using for the message? What are the stories we're going to provide? Because we want to get objective evidence to say, here's the message, here's what's going on. Subjective narratives to say, this is why it matters. This is why it matters to you. This is why it matters to your community. But not just the message. We need to think then very clearly about who are the messengers that people are likely to trust the most. And we need to equip those people with those messages. And I think that in different places, it's going to be different. But the principle behind the strategy is, who are people most likely to trust? And we need to then engage with those people. And I think, for instance, in a lot of faith communities, the faith communities have actually been some of the harder communities to work with. And that's not unusual with public health issues. Faith communities are sometimes quite difficult to engage with. But I'm not really sure that I see governments working hard to say, here's what the message could be. Let's convince you so that you could be messengers for us. So, to me, find out who the trusted people are, equip them with objective and subjective narratives, make the message as simple as you can possibly make it. You want to have catchphrases. You want to have things that are about your neighbors, about that get people to kind of think beyond themselves. I think that those are important principles, but every place the messenger is going to be a little bit different, I would argue.
Great, thanks, Matt. Tabani, I want to turn over to you 2 questions. I'm going to combine 2 questions because I think they have sort of, they're related to each other. One is pre-submitted to us. This was kind of, what policy and regulatory tools do we have to hold pharmaceutical companies accountable for vaccine inequity? And tied to that, that's a tough one. I'm turning it to you, Tabani, but also, if you could also, Gautam Nair, who's a colleague of mine, is asking, to what extent is financing and funding by developed countries a constraint for full vaccination? And I'm putting these 2 together because I feel like one way to hold big pharma accountable is about the thing they care potentially somewhat about, which is making money as well. And so, is there financing tools we can use to kind of combine the 2? So why don't I turn this to you, because this is something you must be confronted with all the time.
Sure. I think from a policy perspective, the immediate one that comes to mind is transparency about their supply schedules, and who is where. I mean, we have been spending time second guessing them in terms of who is where in your queue. As COVAX, we've been arguing, can you get us in front of the queue? But the truth is, we don't know how long that queue is. They give you reasons of why they can't supply you, which, when you look at them, are very unconvincing, or they are not solid enough, and yet you have got to take them at their word of those superficial reasons. So I think they need to be a little bit compelled on, please show us your supply schedules. How do they look like? Be transparent about those. We don't care about your pricing, but show us your supply schedules. At least give us a sense in that regard. In terms of the development, the financing, I honestly think at this particular point, financing from countries probably tied to the comment that Matt raised is an important element when we really think about the fact that COVID and the pandemic is here to stay. And so we have got to think about it with a long-term view. But in the short-term lens, I would actually argue that money has not been a limiting factor. There's been more issues that are a limiting factor before we can get to money as a limiting factor.
Great, appreciate it. Rebecca, I want to turn, I'm going to go slightly out of order in the questions just to kind of keep this flow of conversation going. Even though this is kind of directed to Gavi, I want to pose this question to you. This is from Ipsita from London, who's one of our alums, was at the Gates as well. And the question is it time to think about democratizing the R&D process or so-called drug discovery process, taking some of the capacity away from big pharma? Why are we so reliant on big pharma driving discovery exclusively when country governments everywhere can be partially subsidized with such innovations? And then it's kind of pushing on Gavi, but I'm going to have Rebecca, you answer on Gavi's behalf for this one, which is to say, why can't Gavi do this? Why can't Gavi, why can't we have a Gavi or Gavi-like structure for drug discovery? So if you can tell us, and you've thought a lot about this, obviously, so.
Wonderful question. I can't answer it in a minute. I will just remind us that CEPI grew out of the Ebola crisis, and Suri Moon, a wonderful colleague who used to teach governance and was part of CID as well, wrote a beautiful piece in the New England Journal reminding us now we're seeing the effects of CEPI in this crisis. So it needs to get further investment. It needs to be more embedded in the multilaterals that we've just mentioned. But they do have a $3.5 billion plan to tackle future pandemics, future vaccine development, and that discovery process. Remember, they're competing against the nation state and the resources that the nation state can so quickly leverage and optimize. And that is complex. So the work of cooperation is telling. And I'll just point you to our article, because what she shows you is the nation state moves faster than the EU, moves faster than the bilaterals. And once again, we've created a race optimization versus global cooperation and leveraging infrastructure like CEPI for vaccine discovery.
Thanks, Rebecca. Let me move to there's a question back to you, Matt, which is very specifically to you about the Rwandan case, but I want to use that as a question to all three of us again. And I want, again, I know, Rebecca, this is unfair, but I also want very quick responses on this. Matt, the question to you was, you gave a good example of Rwanda as a good system for development, for delivery of vaccines. And they're asking, what would you attribute other African countries' failure of delivery to? Lack of political will to deliver, or something else? If you can comment on that. And then the other question I want to ask you, because Matt gave one example of a positive story, I want to see if you have any quick examples of positive stories, both you, Rebecca, and Tabani. Matt, go ahead.
So the first thing I would say is when I spoke about Rwanda, I was literally talking about some cold chain, some cold storage facilities that they had. I think that sometimes, even in places like Rwanda, I'm still waiting to see what things look like there, right? Things look like they're doing fairly well, but there's a lot of places where vaccine distribution is working really well. I would say we're still kind of saying, can they get it out to some of the rural areas, etc. And the example I was providing there was saying that there are advances that countries have made before COVID that they can leverage now. And that becomes really important. And that's why we need to think about a systems approach. And countries that have actually developed like systems, not in the health sector, but around trade and around economic growth, etc., have found that some of those things they can leverage for health. And we need to be thinking about that more in these countries. the countries, you're asking where countries are not doing as well, where they're not making vaccines as available. Is it because of money? Is it because of logistics? Is it because of capability or politics? I would argue that the stories are always a little bit different, but they always have a little bit of everything, right? And all of those things interact with each other. Sometimes I think we look at political will and we think, well, political will is the driver, but sometimes when I speak to the politicians are saying, I need to be really careful what I communicate and promise to my population, and I don't know if we can pull it off. So, I don't want to be kind of going out there and saying, this is what we're going to do, and I don't know what to do, because, it's hard to make that promise. So I think that, political will, administrative capability, financial competence in a system, these things are interactive, and kind of thinking about them independently of each other, I think is not the way to go about it. I think we need to be saying that we need to be engaging with all of them, and we need to be building confidence in systems. And I would say we need to be looking at different places and saying, where are the positive deviants in those places? What can we leverage? Where can we start? Let's build confidence in the system and work from there. And I think that there's probably examples in most countries where that is happening, and then there's examples in most countries where it's not happening as well.
Tabani, Rebecca, back to you. Very quickly, positive stories.
I was concerned because I have too many positive stories. I think, let me pick one, and it's a very minute one, but before this, the pandemic, we would not move vaccines between countries. But when we faced big vaccine hesitancy in DRC, we saw that a lot of vaccines were going to be wasted. And we redeployed those vaccines to Rwanda, to Angola, and to Kenya. And we broke rules. That's not how we normally operate. But I think this showed us that maybe we have created and begged the system not to be as agile as it can. And that was a positive story. I don't know whether it's one that we want to continue, but in this particular situation and setting, I've said we have to improvise. And so for me, the good story is that the ingenuity of being able to improvise has not been lost. And COVID is offering us an opportunity to learn and to grow.
A sidebar I'd love to just add is that the vaccine mandates have worked in the United States. So if we view that only 34 police officers in New York City remain unvaccinated out of 35,000 police officers when we had a November 1st deadline. And so we have to remember, if we tie vaccination to people's understanding of economic security, conforming to some social norms, this is your responsibility as a community member with the rollout, we will improve the speed and the equity and decrease transmission. And I'm hoping other countries will see this example and begin to initiate vaccine mandates faster, which actually improves both equity in the longer run. So if we look at the view from the United States, kind of the research evidence shows it improved vaccine intentions, it viewed uptake, and I think this will be one of the success stories of the pandemic.
We are sadly out of time. I just wanted to acknowledge there were a couple of questions from Karianne and Leah about equity within country issues and stuff. We've talked a fair bunch about that, so I think we've addressed several of those comments. I do want to leave with this kind of positive thought, which is, as challenging as I think the situation has been, I do think there's a lot of glass half full that our panelists have acknowledged as well. And honestly, to me, the biggest half glass full is the fact that these things are being debated in ways that I haven't seen before. Debated both at kind of academic levels, as we're sitting at national levels, at international levels, at local levels, at community levels, in the private sector itself. And I think the fact to me that that debate is beginning to happen and these serious questions are being asked more than they were before, I think is a unique opportunity, is a unique moment in our history. My hope is, and I'm using Tabani's name means joy, and I want to hope on, I want to end on a joyful moment, which sounds a bit weird to say this is the biggest tragedy we have faced in the last 100 years. But I want to still end with this joyful recognition that there is a lot to celebrate about, both at the individual frontline worker level and at the national leader level and at the lab scientist level. At all these levels, I think there are amazing miracles that have been working. And my hope is that as much as we discuss kind of the challenges and the lessons and the next things we need to do, we recognize the momentum that this joy, these successes should give us, and frankly, the pure happiness to say that, look, we can deal with this. We will be better because of this. We will come out stronger. With that, I thank all the panelists. I thank the audience members. I hope to see you in a couple of weeks in our third series, which will be on macro and growth and how COVID has affected that. Thank you so much. Have a great day for the rest of you.
Thank you.